Good evening. My name is Selena Joffrey, and I'm the Director of Business and Policy at Asia Society Texas Center. Thank you for joining us this evening. Tonight's program is part of our COVID-19 New Reality series and addresses a topic that has been on many of our minds, the COVID-19 vaccines. Within a year of the first COVID-19 case being reported, almost 2 million people worldwide have lost their lives, with over 350,000 deaths in the US alone. However, with the Pfizer and Moderna vaccines now being administered in the US, there's a light at the end of the tunnel. As vaccines become more widely available, new questions will arise around which vaccine should people get, and will they be willing? How long can a vaccine guarantee immunity? And what should we expect in the next few months? To address some of these topics, we're honored to welcome Dr. Barry Bloom, Research Professor of Public Health, Professor of Immunology and Infectious Diseases, and former Dean of the Harvard School of Public Health. He's widely recognized for his discovery of cytokines and research in the area of immunology, infectious diseases, vaccines, and global health. In 2003, Dr. Bloom was also invited to meet with the Chinese Ministry of Health to advise on how they could have responded to the original SARS epidemic more effectively. Our moderator is Apurva Mandavali. She's a reporter for the New York Times, focusing on science and global health. Apurva is the 2019 winner of the Victor Cohn Prize for Excellence in Medical Science Reporting. She's the founding editor-in-chief of Spectrum, an award-winning news site on autism science that grew an audience of millions. Following the program, we'll be taking some viewer questions, so please share your questions via the YouTube comment box. Before we get started, I would like to share that Asia Society is an educational institution promoting cross-cultural understanding for a more inclusive world. Many of Asia Society's programs, like this one, are free. Please consider supporting our work through a tax-deductible gift by texting Asia Society TX to 243725. We hope you enjoy the program. Thank you.
Thank you, Selena. Dr. Bloom, I'm really looking forward to this conversation, talking about vaccines. I think a topic that you and I have both been immersed in recently in different ways. In a somewhat bleak year, as Selena said, now we have vaccines emerging as sort of a light at the end of the tunnel. We have 2 vaccines authorized for emergency use, the Pfizer and the Moderna, and we've got several more on the horizon. And these vaccines have often been described as a success story and that this development has been much faster than usual. Do you agree with that assessment?
First, let me say it's a privilege to be able to talk to the Asia Society and to be able to have a conversation with you, Apurva. And I would say to anyone in the field of immunology or science in general, it has been astonishing to go from an unknown virus whose DNA sequence was put up on the web in January, 11 months later to have 2 vaccines, 94% protective, tested in over 500,000 people. Yes, it's extraordinary. The quickest vaccine ever made was mumps. That was made in 4 years. The longest that I know of is 27 years for typhoid fever. Chickenpox was 14 years. Vaccines have been very hard to make over a long period of time. And the new technologies have revolutionized how we think about making not only COVID vaccines, but vaccines for the future.
And I can see how the speed has been just a fantastic thing, especially for scientists to see. But the pace of the development has also made people somewhat nervous and hesitant to take the vaccines. Is there any reason for people to worry that these vaccines are not as safe as the companies have said?
I think it's a really important question. I'm appreciative of the question. In their enthusiasm to launch this rapid program, the phrase Operation Warp Speed summarized the aspirations of the politicians in Washington, but terrified many people who wondered, if all vaccines have taken a long time and we have one really quickly, is it really to be taken seriously and safe? I wrote a piece called "The Race for Vaccines Has Been a Lot Slower Than You Think." The technology for these two vaccines emerged over about 20 years. They were trying to use RNA to cure cancer and genetic diseases, hadn't thought about vaccines, and there didn't seem to be a pandemic at the time that would have required it. But they learned an enormous amount over the 20 years of how to modify the structure to make it active, work, and not fall apart once it got into the body. And then about 2006, after H1N1, there was a concern that we might face a pandemic. In 2009, the country launched a national pandemic influenza plan. We actually had a plan, believe it or not, of how to deal with any pandemic that came. And in the middle of the around 2015, with the great advances in molecular biology and genetics, it became possible to think about not making vaccines for one at a time as each new pathogen came. But would it be possible to use a single technology or set of technologies that you could just modify slightly and quickly to accommodate making an immune response to any new pathogen much quicker than starting from scratch? We call these platforms. Messenger RNA is a platform. We can use it for COVID. We can use it, and it was used for MERS. It was used for Zika. So it's a platform that you can, like word processing, you can cut and splice the RNA or cDNA to insert what you want from the pathogen of interest in a platform that you know a great deal about, which is what the public has not realized, has a lot of experience before COVID. And in fact, the platforms existed before the virus existed, at least in our knowledge. And so it was a matter of taking a general technology and making it specific for the new agent. And that has been done astonishingly well.
So in other words, it sounds like, even though to us it looks like the development was very fast, and it was, it's really standing on the shoulders of years, maybe decades of scientific research that came before it.
I think that's exactly right. And I would add, while the science has moved incredibly quickly, the testing is the same as for any other vaccine that has undergone clinical trials. Clinical trial outcomes depend on not how fast you get the answer, but how statistically significant the result is. And that depends on the number of what's called endpoints, the number of people who get the disease. If you don't have a lot of disease and you test a vaccine, it may take a long time to get the critical numbers to tell you that it's 95% effective. We unfortunately are in the position for the country, but not for the vaccine producers. We have an awful lot of COVID, and the trials have gotten the same degree of certainty as any prior vaccine trial. They've occurred a bit more quickly because we have a lot more of the disease than many other diseases that vaccines have been tested on.
So that's all very reassuring to hear, and makes it seem as if it is actually quite reliable. So now that we know that the vaccines are safe, I mean, everybody wants to know, when can I get one? And it seems that the CDC has set up some categories allocated to specific groups, recommendations on who should get the vaccine first. Can you walk us through who gets the vaccine first and when the average person, with not very many health conditions, let's say, can expect to be vaccinated?
So let me say that I have the privilege of serving on the Commonwealth of Massachusetts Governor's Advisory Committee for allocation of COVID vaccines. And one of the crazy things about the United States healthcare system is that everything is state organized rather than nationally organized. So there are 50 health systems. Hopefully the federal government would assume the role of coordinating, which they have not done very well, and that has left the states on their own. The CDC is a national agency, and they have worked hard to provide guidelines, as have the National Institutes of Medicine, Engineering, and Sciences. These are guidelines. And the question then is, what is the basis for deciding who goes first, second, and third when you have a very scarce resource? And I think certainly in the Commonwealth of Massachusetts, but in all of the reports, ethical principles have prevailed. How do you provide the maximum benefit for a scarce resource with the minimum of harms? How do you provide the fairest allocation with a scarce resource? And how, when there are inequalities in suffering the risks for disease, how do you arrange to compensate to some extent for the health inequalities? Those are very big trade-offs. One could think of them as trade-offs between saving lives, which is the highest priority of any medical intervention, is keeping people alive and hopefully safe. And the second is to keep them out of hospitals, because when they are full, as they are in Los Angeles, people with other conditions, heart disease, kidney disease, strokes, cancer, are unable to be treated. So the consequences of filling hospitals are enormous. And while healthcare workers are highly at risk and exposed, they're not the group that dies most. That group is people over 75 and below that over 65. So each state has taken those guidelines and tried to find a way to get the maximum benefits, fairness, and help with the inequalities. And so the recommendations have been from CDC that we start with a set of tiers, dealing at the first tier with clinical and non-clinical healthcare workers who see COVID patients with active disease every day. They're at risk, and we need them to keep the hospitals running. An equal priority that has been listed is the people with the highest rate of dying are those in congregate settings, in, for example, nursing homes and assisted living facilities, because they are crowded, they don't have the ability to move and protect themselves, and their caretakers are coming in and out every day from the real world. That has turned out to be a universal high priority. There are civil service workers of police, fire, emergency, healthcare workers, ambulance drivers that are exposed all the time. And in Massachusetts, I'm pleased to say we have made prisons and jails a high priority, because the serious consequence rate, the death rates of prisoners nationwide are 5 times higher than any other group other than people over 75. So these are the priorities that each state has agonized over and tried with the fairest possible way to set guidelines for stages or phases in which vaccines would be made available. Mm-hmm. And Purva, as you know, the new vaccines we have very delicate cold chain requirements. They have to be kept really cold, and they don't last very long if they're not kept cold. So one of the challenges certainly is in small institutions, small hospitals, um, smaller pharmacies that can't use the full amount. How do you be sure that people in the next layer waiting for vaccines can be made available so no vaccine doses are wasted? And the overall premise that we start almost every discussion with is every life counts. How do we take the limited supply and make it save the most lives in the broadest sense?
Well, those are all excellent points, and I can see that ultimately we want everybody vaccinated as soon as possible, but it seems like we're actually struggling to get enough of the vaccines to the people that are made. Operation Warp Speed said we'd be at 20 million by the end of the year, and yet we're at about 6 million as of today. Closer to home to the Asia Society, Texas has distributed 1.7 million doses, and that's second only to California, which makes sense. But like many states, Texas has only managed to use less than a third of the doses. What do you think is going on?
I think expectations have been made unrealistically high when you have promises where one really didn't know when those promises were made. They had to do with political promises more than scientific expectations. I guess I have to say we don't appreciate how complicated it is in every state, with rural and urban, with congregate settings, nursing homes, with budgets at CDC that have been cut every year for the previous 3 years, with public health budgets and departments of public health working at the bare minimum before the epidemic, now being asked to provide 700 million vaccines, 2 doses for every American in warp speed. That can't be done. I'm impressed with the Department of Health, public health people here working 14 hours a day, trying to organize how to get vaccine to 3,000 sites, how to recruit people, students, pharmacists, train them how to deliver vaccines. And it isn't just delivering the vaccine, but training them if there are adverse effects, how to handle them so that they are well taken care of, and that we have enough people trained to provide the vaccines. And of course, we've had New Year's and Christmas, which hasn't made life any more organized. The hope is that the supplies will be more steady, the vaccines will continue to come on a regular basis, that there will be more time to plan where to put them, and we'll have time to train more people in each of the states. It will not probably be smooth until at least February, in my view, but in the process, we will be amping up very greatly the number of first-line health workers, phase 1 recipients of vaccines getting their vaccines. How to get it to your local doctor is going to be a bit more challenging, and we hope that there are newer vaccines that come along by that time that don't require the cold chain and can be distributed much more easily and widely to pharmacies and doctors' offices.
How much do you think is going to change when the Biden administration comes into power, and how quickly can they change?
I think they are trying hard to plan for those changes. I think we have not had great leadership from the federal government. There haven't been the resources to the states. The sole resource in the previous CARES Act was $341 million to provide 700 million vaccines to 350 million people in America is ludicrous. We have 8 million in the previous bill. So the states, once those funds roll out in the new administration, the states will get some funds and CDC will get some more funds. But there are enormous needs for information systems, for example. We have to know who got their first vaccine. We have to be able to let them know they have to come back in either 21 days or 28 days for their booster shot. We have to know if they have prior conditions so that if adverse effects affect somebody with a particular condition, we have recordings and records of that. And we have to know whether they are minorities and underserved populations, so we can see how we're doing on the equity end. That's going to take a lot longer for each vaccine to go into an arm, to fill out the forms, than it is to actually have the injection. And then, of course, we have to have people waiting for 15 minutes to be certain that they don't have an immediate adverse effect. So this is a challenge greater for the states in a way than the Biden administration, but shaking out the funds and getting them to the states, creating the information systems, reporting systems, and coordinating the distribution so that you don't have a promise for so many doses and organize where they will go and then they don't appear.
Mm-hmm. So we've heard a lot of talk in recent days about all kinds of alternate strategies to make the vaccines last us longer. Half doses, single doses, delaying the doses. James, one of our viewers, wants to know, how good is the immunity after one shot? And also, the FDA has now said we should stick with the original plan of 2 full doses 3 weeks apart. What do you think? Do you agree with their decision?
It's a really wonderful question. And the origins of this question is, how do we keep as many people as possible from dying? And I would look at the answer to the question in the short term and the long term. We all want to be sure that people who are vaccinated are protected, but we do not know in any of the present vaccines, because we've only had COVID for just about a year, we don't know how long protection lasts. And to provide a vaccine to someone where we can't tell them the likelihood that they will be protected is a problem. And so we have good data from this 500,000 people who were in the vaccine trials, and those who got vaccines in half of that. We have good data that the vaccines are developing a strong immune response, as good or better than people who've recovered from infection, that we know lasts at least 9 months for most people. Those are facts, those are data. I'm one of those scientists who believe that we should act on the data that we have and collect data for the knowledge that we don't. So I'm happy to say that the suggestions of 1-dose vaccines is being undertaken in the United Kingdom. I have to say that the titers of antibody, the amount of antibody was less after 1 dose there for one of the vaccines than for 2 doses. It was enough to protect against the virus, but how long it will last is a problem. And if you don't get people back in 30 days, that will be hard enough with the information system. What happens if we wait a year? How many people, if they lose their immunity, will we ever find again to get them back? So there are trade-offs by getting more people vaccinated, being best confident of how immune the people we have vaccinated are. So what I can say is there are data in 600 patients that said if you give half the dose of the Moderna vaccine, you got the same immune response. And if you boost that, it should be pretty good. But that's being tested now on an accelerated basis. They won't have to run a 6 or 9 month trial. We'll get the answer by springtime. But I'm one of those people that I've written on several occasions, the most important ingredient in a vaccine is trust. And if you have data and ignore it and go around it or cut shortcuts, you're not only cutting the confidence in the vaccine, you're cutting the trust in the whole system. I'm hopeful we'll get those answers quickly, and I would not be surprised if the half dose for one of the vaccines works very well.
I want to talk to you more about the aspect of trust. It seems like an incredibly important issue. But first, I want to ask you a question that came from one of our viewers. Lelam says, as Moderna's phase 3 trial participants, we received our 2 shots in August 2020. It's been about 6 months. Should we take the vaccine again? This goes to your question, what you were saying about we don't know how long the vaccine's immune protection lasts.
I would say on ethical grounds, no, because you have had the advantage of getting the full immunization. The data as it appeared yesterday indicates that at least for 9 months, the protective antibodies, as well as T cells and memory B cells, all the things you need for recall responses are still there and often going up. And there are other people's at risk for death because they haven't had access to vaccines. I would think there's not a need for anyone who's had the full course to be revaccinated until there's evidence in the population that that's required, until everybody's vaccinated.
So to go back to the issue of trust, public health is so much about messaging. How do we convince people to trust the vaccine? A recent Pew poll showed that somewhere between a third and a quarter of those polled wouldn't want to take one. And a lot of healthcare workers are refusing the vaccine, a lot more than anybody expected. What does that mean for ending this pandemic?
I think it means a lot for trust beyond COVID vaccine, trust in science, trust in evidence that we have to come to grips with as a country. My personal view is when a new product like a new vaccine comes, it is very reasonable for thoughtful people to say, wait a minute, I want to know what the evidence is that this vaccine works. I want to know what the evidence is that it's safe. I want to know what the data are on adverse reactions. I want to keep an open mind and be persuaded by the evidence. I think we have the evidence on these two vaccines, as good as any other vaccine, that it is effective, at least in the time frame we know, and remarkably safe. When I say safe, people are worried about acute allergic reactions that occur within 15 minutes or a half an hour. There are about 2 million people who've received vaccines so far. There are only 21 cases of this reaction reported. That's about as safe as I can imagine any vaccine being, and that's the goal of safety. No vaccine is 100% effective. No vaccine has no adverse effects. This is as good as it gets. So I'm very hopeful that as supply comes out and more people get vaccinated and people that have questions are able to observe with evidence in every state, very few people are getting sick. And over 2 or 3 months, all of a sudden, people in nursing homes are not dying. People are not filling up hospital beds. People are not getting sick. They will say for themselves that the evidence, if the media and newspapers and radio and social media provide accurate information, I would trust the public to make rational decisions. The variable that we have not had for any other vaccines, we've always had anti-vaxxers from the 1880s when smallpox was first made available by Edward Jenner in 1796. The first anti-vaccine societies existed in England. In Massachusetts, the first anti-vaccine group was 1908. So I'm not surprised that there is a group of people skeptical of being asked to take vaccines or required, as the school laws in every state required for kids to be vaccinated. I would point out here, nobody is being made to accept this vaccine. At the moment, it is voluntary. And I would hope when the evidence is clear that people are being protected and the disease is going down and people are beginning to engage back into normal society, we will have a greater demand than we have vaccines. And I'll be happy when that point occurs, provided those vaccines are given out fairly and not to those who can buy their way into the front of the line.
Although a lot of that seems to be happening as well, all over the place. But to your point about people becoming more confident, it does seem like the proportion of people who've agreed to take a vaccine or who have said they would take one has gone up since a few months ago. You've kind of answered this question already, but one of our viewers called Summer wants to know, Although minimal, are there serious side effects such as Bell's palsy and other severe harmful reactions?
It raises a question that's really very difficult to answer. And the question is, when you vaccinate 300,000 people with a vaccine, only a small number of which ever get the disease. That's why you vaccinate so many people, so you have enough cases to be able to know, have you protected with the vaccine better than with the control or the placebo? When you're dealing with 300,000 people, somebody's going to get a heart attack. Somebody's going to get a stroke. Somebody's going to commit suicide. Somebody's going to get run over by a car, and somebody's going to get a Bell's palsy. And the challenge that is really very difficult is, how do we know whether that is a chance phenomenon that occurs in 300,000 people, or all of those are in the vaccine group and none of those are in the placebo group, and you have to keep an eye on it and worry about it. And with vaccines and Bell's palsy, there is a history that virus infections can cause, in some individuals, unpredictably, a paralysis of facial nerves called Bell's palsy. So it is not impossible that a non-infectious, non-live vaccine might do the same. But 4 cases does not make definitive evidence that it has anything to do yet with the vaccine. That's why we need to collect all the paperwork to measure any adverse effects over the next 2 years to know what the real long-term effects of the vaccines will be.
Is one way to convince people to take the vaccine to pay them to take it? One of our viewers, May, says, Houston Methodist offered workers $500 to get the vaccine. Should more hospitals follow suit? Should the government pay citizens to get the vaccine?
From an ethics point of view, if it means that anyone gets vaccines ahead of those that are most vulnerable, it questions the fairness of the allocation of vaccines. And there is enough skepticism about how fair the allocations will be, such that if people have more money, does that mean they have a greater access to vaccines? And will that compromise people's belief that the process has been fair? I am not keen on that. I think a more realistic problem, because there are a lot of organizations like school teachers and people who are working in small businesses that don't have the resources to pay people to do that, that are at very much risk. That unlevels the playing field and makes it, I think, less fair. And particularly vulnerable populations, African Americans, Latinx, in vulnerable areas in crowded and poor housing, they sure do not have the resources to buy their way into the vaccines. The other side of that is more challenging in a way, and I think more difficult. And that is, it is within the law, as I understand it, for a business to require that people, once vaccines are available, to work in their building, in their business, to require vaccines. That has been a case with influenza vaccine for hospital personnel, so that they don't give influenza to elderly patients in emergency rooms and in the hospitals. That's a legal possibility. I would hope to keep everything voluntary and reward things by doing good for society as well as yourself. There are intangible assets in this world that money can't buy, which is knowing you're doing something good for somebody else. Everybody who takes a vaccine is protecting everybody else in their family and in their environment.
You mentioned Black and Latinx communities. So let's talk about that for a second, because those are some of the communities that are most reluctant to take the vaccine and have the least trust in the process, if you will. So how do we reach those communities? How do we communicate in a manner that fosters the trust? And how do we ensure that they actually receive the vaccines?
That is perhaps, of all the challenges the states are facing, I think perhaps might be the biggest. And the reason is there are historical reasons, as you know, of the Tuskegee study where people with syphilis did not receive treatment, although they were promised treatment. There were experiments done on Blacks that was done without informed consent or permission. I would like to believe those experiments were 100 years away from anything that happens in recent times, but one can't be certain that there aren't egregious things done from physicians or health workers who have particular biases. So there's a historical origin that waving the hands or providing evidence from 6 scientists or 2 newspaper correspondents is unlikely to overcome. And there, the mantra that we hear are 2 things. Who are the trusted people in the community that don't work for the government, that certainly don't work for the companies and don't work for the scientists, that are likely to be telling people, because they have the same history and the same experiences, likely to tell them the truth that they can believe. And so one of the things I think would be really helpful is providing as much representation, information to the religious community, the athletic community, the movie star community, anyone who has sway in any community, not just people of color, but there are plenty of people who are white and skeptical of government that might take the word of trusted newscasters, trusted movie stars, and we have to have their help. Let me just remind everybody, if they're old enough, and if they're young, then tell them, the largest vaccine campaign in history in the United States was the campaign for polio vaccine in the 1950s, where almost all of the kids in the United States were vaccinated against the new polio vaccine. And what's interesting about that is none of that was paid for by the government initially. The Salk vaccine was paid for by a foundation called the Foundation for Infantile Paralysis. And all of the advertising marketing, it was the first social marketing campaign in health of which I am aware. There were placards, there were pictures of kids with braces, there were pictures of people in iron lungs that got to every kid. There was the March of Dimes. Every child was asked to contribute to vaccines to prevent children. And it happened that the President of the United States had poliomyelitis and became the #1 trusted person in the country with that. I'm a great believer that the government does wonderful things, provides terrific evidence, but they're not as good as the people selling erectile dysfunction drugs and plaque psoriasis drugs at halftime in the Super Bowl. And that's where I want to see a vaccine ad as soon as it comes up in a few weeks.
I've actually seen a lot of Black and Latinx researchers and doctors opting to take the vaccine very publicly and posting photos for some of the same reasons that you're talking about.
I think that's admirable and commendable.
So we've really been talking about just Pfizer and Moderna at this point, but once we have vaccines from AstraZeneca and Johnson & Johnson in the mix, and there's many others behind those, people will have access to a lot of different vaccines perhaps. And which ones should somebody opt to get? Is there one type that's better than the other?
It's very difficult to compare the numbers from a carefully controlled clinical trial of 94% effective and a vaccine of a different brand in a different country given in a different way. That it turns out to be, if you do it with one dosage, it's 90%. If you do it with another dosage, it's 62%. very hard to compare any two vaccines in the real world. There are lots of cases where vaccines have worked well in clinical trials, but when you put them in the real world where people are exposed to whatever the agents are at a different level, they may not be so good. The government said anything over 50% is a good deal. 50% is what influenza vaccines protect against. We lost 16,000 people last year from influenza vaccine. If we could protect half of those, that would have been terrific. So I would suggest comparing the efficacy with what we know now. If they're in the range of 70%, I don't think there's anything to distinguish them other than the cold chain, which makes one easier to distribute, and the other is price. And the new ones coming are likely to be less expensive than the ones that require the cold chain. And they're the ones that I am hopeful will have very good protection. And my understanding is we are likely to have data in late January, early February on at least one of those with US trial data. And if it is as good as I hope it is, it may be a one-shot vaccine. And again, a one-shot vaccine goes twice as far and is twice as less hassle for finding people and getting them back, could have a huge advantage. And if the price is what they have promised, on the order of $3 to $5 per dose, for developing countries particularly, that's a real bargain that would be difficult with the current vaccine.
So you mentioned a lot of numbers. You said 95%, 70%, 50%. What do those numbers mean? What does it mean to be 95% effective versus 70% effective? And one of our viewers, Sam, wants to know, does that mean that in 5% of people, the vaccine won't be effective?
Yeah, that's exactly what it means. And it may be more than 5% in the following sense. The endpoint for the vaccines in all of the trials has been based on the premise of keeping people from dying, people from being sick, and preventing people from having COVID-19 disease. What we want from a public health point of view is not only to prevent people from getting sick, we want to be sure that they don't transmit the virus. And those are things that are much more difficult to measure. How do you know that someone is actually transmitting or not transmitting? And there are current trials in follow-ups to the existing trials to begin to look for that. So it says that if you're 95% protected against getting sick, there's a possibility you could still transmit virus and contribute to the pool of people who are able to get sick. So we need to know more about, just as you say, Apurva, what that 95% really means. It means that it's pretty damn good to be able, in a trial under carefully controlled conditions where nobody is lost over, all the data are collected and measured and observed independently by 2 FDA committees and the CDC. It says they're awfully good and that they're pretty safe. And we know what the case is as we watch Los Angeles shut down and people yesterday having the highest rate of hospitalization in history in the country with an infectious disease. You do a lot better taking the vaccine than the alternative of not.
You mentioned that we don't know yet whether the vaccines also prevent people from transmitting the virus to others. When will we know? A viewer, Summer, wants to know, when and how will we determine whether the vaccines prevent asymptomatic transmission?
I would guess that the best way to know that is in a captive population like college students, where there is an enormous amount in many schools of repetitive testing. And there, if you test for people and you find out in one dormitory on one floor, 1 out of 60 students is positive. And another student in the same floor has been vaccinated, is negative, but his 4 roommates have all become positive. And we can measure infection by measuring antibodies to the virus that is generated by someone who doesn't have the vaccine. If they have antibodies, it is likely they have been infected. So it is possible to do that, but you need a population that you can follow over time, identify transmitters, i.e. people that have known infection, and follow up how many people in their orbit are they transmitting to. And of course, that will be affected by whether you wear masks, whether you live in a fraternity versus a dormitory. You can measure what goes on in a dormitory, very much different in the Greek societies. And all of this makes it more complicated. But I would guess within 2 or 3 months, we will have a very good idea on these vaccines, how effective they are against transmission. I would say intuitively, anybody who is exposed to the virus and doesn't get sick and generates an antibody response, even if they're not completely free of virus, will have less virus than someone who has a raging virus infection is likely to have. The vaccinated person is likely to have less virus. And transmission does depend on the amount of virus that you shed into the environment.
You said, the college students would be a great population to study this. And are there studies like that? I mean, I knew of one that was supposed to happen and has been shelved. Is there, because of lack of funding? Are there other studies that you know of that are doing that?
I believe the companies are trying to do studies of transmission, but I don't have any insight into what populations and how they're doing.
The companies are just looking at trial participants. They're looking for the N protein antibodies to the N protein, since the vaccine only elicits antibodies to the spike as a measure of infection. But so they'll know how many people were infected. I'm not sure unless they're doing close contact tracing, which they are not.
Well, I think what they are doing now is all the volunteers have given blood samples, which is very nice, and they can measure whether they actually have antibodies to the spike protein, which we know is the best shot at being a protective antibody. But they can also measure whether those people have antibodies to another antigen, the N protein, right, which says that they have been infected and they got it from somebody. Right. But it's not easy to do. And I think your point is well taken. Any large population study, which is what we do in public health, costs more money than anyone has at the present time. And we hope the new funding will support those kinds of studies because we really have to know them.
Right. I mean, and the companies, as you mentioned, are looking at the nucleocapsid protein antibodies, but they're not looking at who else was infected around those participants. So I'm not sure exactly how they plan to find out. Well, anyway, there are a lot of questions from our viewers that are very specific about specific groups of people. So I'll just ask a few of those before we sort of take a long view on what we can expect down the line with vaccines. One of the questions is about pregnant women. Diego says, would you recommend a vaccine for a pregnant woman? My wife is pregnant and we're worried there's no data about potential side effects on the baby.
It's a really important question, and I would just add to that question. We have no idea of the efficacy and safety of the vaccine in young children. So let me start with the kids first, and if I may work backward to pregnancy. There was a debate and presentations at the Advisory Committee on Immunization Practices at CDC as to whether the vaccines, even before we knew the results of Pfizer and Moderna's phase 3 trials, that the vaccine be tested in children. I testified opposing that, and the logic is twofold. One is until you know what the safety is in healthy adults between 18 and 55, I would find it unsettling to volunteer my kid or my grandchild to get a vaccine where I don't even know it's safe in healthy young adults. We have passed that first stage. We know that it's effective. We know it's safe. And we know that several of the companies have moved down between 18 years as the lower cutoff to 12 years. The second thing is when you get down to 2 years and 3 years and 4 years, as in the ordinary children vaccines, we also have to know whether the doses have to be reduced to compensate for the small trials of children. And that requires more trials. Kids are not miniature adults. They're things unto themselves. And hence, we're going to have to test what doses are safe and still generate protective antibody responses, at least in children, before we give it to them. So I am pleased to say that both companies are undertaking trials. They will not take 6 or 9 months. They're really testing minimal duration just to be sure that they can assure their safety and they can assure they're generating what looks like a protective response. On pregnant women, again, that's a heterogeneous group. Are you pregnant at month 1 or month 9? It makes a big difference in terms of circulation of antibodies, blood, and antigens, hormonal differences. It's a complicated business. And I think the best answer on that is twofold. One is, I think trials, as I understand it, are being set up in departments of OBGYN, seeking volunteers to test for that. But one of the things that I found interesting is that 75% of healthcare workers are women. And they, in the first group, are healthcare workers working in hospitals and hospital health settings. Many of those, all of those, in the first tiers will be offered voluntarily whether they wish to take vaccine or not. Many of them are choosing to do so, many are not. If we keep good records on those and follow them through their pregnancies, I am hopeful. These are not randomized controlled trials, but they will provide evidence, I am hopeful, that it has not had any adverse effect either on the moms or on the babies to be delivered. But those are data yet to be obtained.
So in the meantime, what would you say to Diego?
If I were a pregnant woman, I would take the vaccine.
Okay.
We know that having serious COVID illness relates to wasting of babies and premature death, miscarriages, and that's sufficient that I would think the chances of an adverse effect on the offspring would be much less than that. Don't forget, we do immunize moms against other infectious diseases with the purpose, like hepatitis B, of protecting the baby. So it is not unusual to immunize a mom both to protect her against neonatal tetanus, for example, but that also protects the child who has maternal antibodies. But we want to just do this in a way that turns out with data to be shown to be safe and convincing so that people don't have to raise that question.
We only have a few minutes left, and there are a couple of questions I really want to get to with you. One is, will we need to get a new round of vaccines every year like the flu?
Answer, of course, like all of your questions, is we really don't know, and I can guess about as well as anyone else. If the vaccine really works and isn't 100%, and people are not 100% willing to be vaccinated and willing in the next year or two still to wear masks and avoid unnecessary crowds where not everybody is vaccinated, then I think we're going to have this virus with us for a long period of time, just like the original cold viruses. The close relatives, besides the original SARS, are two sets of coronaviruses, one set of which is a major cause of the common cold. And everybody gets common colds. It has been so reduced in virulence that it doesn't kill very many people. But we don't have a vaccine. We don't vaccinate for that. But we get a certain level of immunity because we get it all the time. I think the general expectation is we will have COVID either seasonally in the colder winter times as we are now, but we will not have epidemic and pandemic proportions. Ideally, we would like to end up like SARS-1, where 8,214 patients were known to have the infection, and with public health measures alone and without a vaccine, the virus was not hardy enough to travel to anywhere in Africa and most of Asia, and the virus disappeared. And we now have a new one, and we hope vaccines would help this to disappear. But I think most of us are counting on it to be around, even after we have 70% of people vaccinated, if we can get that far, for some time. Once we know how long protection lasts, I think there's a very good chance that we will need booster shots, as we do for many other vaccines. For measles, that's teenage years after a childhood vaccination series. For other vaccines, flu, it's every year. I think the companies are counting on that to provide a good source of income in the investments they've made in these vaccines. So my expectations, we will have continuance, hopefully at low levels of virus, and continuance of people getting immunized and everybody being protected, including the companies who've made these vaccines at their own risk without knowing if they were going to work or not.
Well, let's talk about these the bombshell that Britain dropped on us right around the end of the year with this new variant, and also the new variants that we now know about that are coming up in South Africa and in Brazil. The one from Britain seems like it's more transmissible. The one from South Africa and Brazil seem like they have a mutation that makes the vaccines a little less effective. So what can we say right now about these mutations and how they might affect the effectiveness of the vaccines?
So I would start with the fundamental principle of genetics, which is Darwin's survival of the fittest. And by that, I don't mean the survival of the human species relevant to the coronavirus as the threat. Every coronavirus makes mistakes. It makes one mutation on average about once a month. One of the things that has been surprising to me, certainly, and I think many, is the viruses that have emerged recently don't have one or two or three mutations that we would have expected. They have 23, 17 of them changing the structure of the virus protein that we have the antibodies in the vaccines targeted to, and several of those in the exact places we need to be protected. Anyone who says that's not worrisome is not telling the truth. So this is a worry, but the probability of getting every possible site within the region that is required to bind to the body's receptor is very low. So the virus is trying to survive. It makes mutations, and the one that is best fit to the environment survives. If the antibody binds to a site on the virus, so that it mutates away from the antibody, that is the exact site on the virus that has to bind to the receptor on host cells. So it may learn how to escape from an antibody, but then it loses, for the most part, its ability to bind to cells. So mostly evolution in the long run is working, in the short run is working for us. We will find and are finding mutants that have lost the ability of serum from recovered patients to neutralize it in a test tube better than the original virus that we studied in the beginning. But the fact is they are still neutralized by other antibodies from the same people. Some people have no diminution with the same changed virus, and others have maybe a 50% or 60% lower efficiency. We make one of the great things about the diversity of human beings is we do everything diversely in creating, as well as creating diverse immune responses. So when I said, how long do antibodies last? They last 9 months. That means for some people it lasts 6 months, for other people 20 years. We make very many different antibodies, and depending on what the constellation is, the chance that you would be resistant to every single part of the virus protein is very, very low. I will give an example from my own lab. I made the first mutant in measles virus. And we started by taking serum. Everybody in the world has antibodies to measles. So we just took serum where we knew everybody was protected either from infection or the vaccine, and we could never make a mutant. We made one monoclonal antibody, and in the first experiment, we got a mutant. And what that says is you can mutate any one site, but to mutate all of them to escape all of the antibodies that people can make is a very low probability event. And if that happens, and it's not statistically impossible, the good news is these vaccines were made in 11 months. It would take 6 weeks to substitute the new spike protein that is mutated and put it into an RNA vaccine or into an adenovirus vaccine, and we could upgrade the vaccine very rapidly so that we would have newer versions. And I would point out, with rare exceptions, no vaccine that worked the first time from 1796 with the cowpox vaccine has ever been the one that is the one that has lasted. All vaccines are iterative. We make improvements in them all the time. I'm really optimistic if this does occur. The companies, the platforms enable rapid production of more effective vaccines.
I'm really glad that you are being so optimistic. That's a nice note to be at the end of the program. Just about. I have one last question for you, just so we can have some final thoughts on this. Everything we've been talking about makes this seem very much like it's a race between the virus and the vaccines. How do we make sure we win this race?
I think that the key element here is time. So the mutation rate is fixed, in essence, 1 mutation per month. As they accumulate, we can make them, in certain circumstances, occur faster with lousy immune responses or treatment of people with convalescent serum that may not be as good as a natural immune response. The more virus in the environment, the more variants. The quicker we get the viruses down, whether by public health means of identifying patients with getting testing up and having people quarantine for 2 weeks or contacts isolate, get those numbers down means fewer virus, fewer mutants, fewer possibilities statistically of escaping. And the second is, if everybody takes a vaccine and they actually do reduce disease and transmission, that will speed things up dramatically. But it's the number of viruses floating in the community that determine how safe we are going to be and how quickly we're going to be able to get rid of this problem. And the fewer viruses out there, the quicker we can go back to normal life.
That's a great note to end this program on. Thank you so much, Dr. Bloom, for joining us this evening. And to our viewers, we hope you enjoyed the program. And you can learn more about upcoming programs and webcasts through the Asia Society website. Thank you.
Thanks, everybody, for watching.